For the opportunity. Let me share my screen here and see if that comes up. Is that visible to everyone?
That's good. Thank you.
Yes.
Okay, let me try to pull my screen up so that I can see it too. There we go. So today, thank you for the opportunity. Really love talking about peritoneal disease whenever I can, partially because it's such a rare disease. I don't think it gets the attention that it deserves in many instances, and that's led to some strengths and weaknesses in trying to treat these patients. And so I'm going to talk about systemic and medical management of these folks, and Peter will, I think, talk about the surgical side. And so I think, I guess first off, to give my disclosures, I do a lot of drug development clinically, especially, so I work with a lot of drug companies on that. But so what are peritoneal cancers? Where do they come from? How do we treat them? These are kind of a diverse set of tumors. It's not isolated to a single type of tumor, although there is primary peritoneal cancer. If you look at colorectal cancer, probably 10 to 15% of colorectal cancers will metastasize into the peritoneal space and be isolated in the peritoneal space. About 20 to 30% of colorectal cancers will have other parenchymal metastatic disease, but also have peritoneal disease on top of that. We happen to see a lot of appendix cancer at our institution. Probably of the metastatic appendix cancers, 95% or more probably end up with peritoneal disease isolated. A few end up with parenchymal metastasis. As you would expect, mesothelioma originates in the lining of the peritoneum. Is all mesotheliomas are peritoneal disease almost by definition. Other diseases, gastric, ovarian cancer as well, develop a significant chunk of peritoneal disease. I'm going to hold off on the ovarian cancer partly because that tends to be managed within the gyn-onc space, and talk mostly about kind of the group of peritoneal cancers. But anything can develop peritoneal cancer. I've seen peritoneal disease from melanoma. I've seen it from breast cancer, from lung cancer. But those tend to be treated medically as from their cancer site of origin, as opposed to being treated like we would other types of GI type peritoneal cancers. And so peritoneal carcinomatosis, from wherever it starts, is generally very much a multidisciplinary problem. And as much as it pains me as a medical oncologist to say, I think surgery is really the most important part of this process. I think many of these patients need surgery plus or minus high-pec heated intraperitoneal chemotherapy. But you have to choose your patients correctly. Those are not small procedures. There's procedures with fairly high morbidity. And so you need to have the right patient population to be able to go into those surgical procedures without running into serious problems. I think almost all these patients need systemic therapy. Surgery by itself isn't going to be enough. Chemotherapy is not going to be enough. And I think the one thing that really is overlooked is all of these patients need very good palliative care, not just hospice care, but palliative care from the beginning. They have unique subsets of problems that have to be dealt with. And it helps to be doing that within a group that treats these patients on a regular basis. I think, unfortunately, if you don't treat a lot of peritoneal disease, the problems that they have can become overwhelming very quickly if you're not staying aggressive and staying on top of them. And so I'm going to go through 2 or 3 of these diseases and talk about kind of the systemic therapies. And I'm going to start with probably the most prevalent in that colorectal cancer, hits the most people that we see within the peritoneal disease community. The downside to that is it's probably, from a systemic perspective, the one where we have the least amount of good data or novel therapies for peritoneal disease in and of itself. And so from a non-surgical perspective, the big question for me is there anything special about colorectal cancer? And, yes and no. I think, and just to give kind of a background, peritoneal cancer from peritoneal carcinomatosis from colon cancer is pretty miserable. In general, the overall survival from peritoneal carcinomatosis, if you have colon cancer, is bad. This is a couple of fairly old studies, actually. This is on the left is the Dutch group, and probably the first good publication of randomized data between colorectal cancer patients getting surgery versus just getting medical management. And on the right is Dominique Elias's group out of France with an update that was done over about course of about 10 years later. And what you see is, for the most part, if you have peritoneal disease and you don't get surgery, your survival is pretty poor. And I would quote most of my patients, if they come in with colorectal cancer and they have peritoneal carcinomatosis, the median overall survival is probably around 18 months. in the general kind of colorectal population. And that's about half what we would expect for people with peritoneal or with non-peritoneal metastatic disease from colorectal cancer. And so obviously this is a highly unmet need and population that needs whatever help we can give them. And surgery is definitely beneficial. And so one of the goals of colorectal cancer is how can we get people to surgery? Because as you can see in these two survival curves, surgery definitely benefits our patients. And after those studies were published, the uptake of cytoreductive surgery and HIPEC really was increasing. In fact, the Dutch group here looked at their data after the publication of their kind of seminal paper 20 some odd years ago, and saw that the uptake of patients with peritoneal disease that are actually getting cytoreductive surgery was going up over time, which is great. And if you look again, this is kind of updated survival curves that they published 7 years ago now, 8 years ago now. Patients that get cytoreductive surgery and HIPEC do better. Those that get palliative care chemotherapy do okay, but still nowhere near as those that get surgery. And those that just get best supportive care die relatively quickly, unfortunately. And so it really is a case of we need to get these patients as much cooperative care between all of the participating providers as we can. So this is from our group. We looked at Medicare data in the United States, which is our patient population over the age of 65. And we were trying to figure out who gets to surgery, who gets to kind of the multidisciplinary care that they need. And we looked at patients over this 4-year period or 5-year period from 2013 to 2017. And what we found was that, age, even in patients above the age of 65, social vulnerability, comorbidities, and oddly enough, the distance, what we would call one of our peritoneal centers, and there are 20 to 25 in the US that are high volume peritoneal centers. And if you are a long way away from one of those, the likelihood of you ever getting to one and getting surgery is fairly low. And we looked at survival, and this we also included appendix cancer, so not just colon cancer, although the colon cancer is on the bottom panel. Again, for people that got surgery, the median overall survival was 3 years plus, whereas if you didn't get surgery, it was a year and a half, somewhere between a year and a half. The other thing that was kind of shocking that we found was that less than 10% of the people with colorectal cancer that would have been eligible, at least by having peritoneal disease, made it to a comprehensive center and got cytoreductive surgery and HIPEC. That's not to say that we operate on everyone. Again, this is a highly selective population, but 10% is a fairly small number. Appendix cancer, we were a little bit more aggressive, and it seems like more people are getting to that with appendix cancer, which is helpful, but this is still lower than we'd like to see. I think the biggest question from colorectal cancer as a medical oncologist is how can I help my surgeons out? And one of the big questions that we've had is when do we give these patients chemotherapy? If you were to present with oligometastatic colon cancer, in many instances, if you have a single liver met, you might get surgery and then go to chemotherapy in the adjuvant setting, although there's more uptake for neoadjuvant chemotherapy in colon cancer in general. We've been trying to look at, and a number of other sites have tried to look at giving neoadjuvant chemotherapy in the setting of peritoneal carcinomatosis. So this is also from our group, but it was a collaboration between 9 or 10 centers in the United States where we looked at kind of what was the benefit of neoadjuvant chemotherapy. Now, in univariate analysis, it meant that patients had a lower peritoneal carcinomatosis index at the time of surgery. They had a shorter operative time, but there's really no difference in rate of complete cytoreduction or the duration of stay or any of the other kind of complication rates we'd see from a surgery perspective. And unfortunately, it didn't predict overall survival benefit. The only things that predicted survival benefit was how much disease that the patients had, in other words, their peritoneal carcinomatosis index, as well as the completeness of cytoreduction score. Those that had a better cytoreduction lived longer. Now, we're not the only group. There have been about 10 of these studies that have been published in over 100 patients. And all of them have showed fairly similar results, that neoadjuvant chemotherapy does not necessarily affect survival in patients with peritoneal carcinomatosis going to surgery. The downside, these are all retrospective studies, and there's a massive selection bias in the patients that we actually give neoadjuvant chemotherapy to as opposed to those that go straight into surgery. And so the ones that get neoadjuvant chemotherapy tend to have a higher volume of disease, have a worse biology. And so those are the ones we're actually trying to test to make sure we don't take the wrong people to surgery. And so I think you have to, the fact that the ones that got neoadjuvant chemotherapy did just as well as the ones that didn't, says something, because it's likely a much worse patient population from a disease perspective going in. And so I think that's a big unanswered question that we have right now. And so in colon cancer, I give you a few slides and I tell you a whole lot of nothing, because we don't have a lot of nothing, a whole lot of positive information for what to do from a systemic perspective when it comes to colon cancer and peritoneal disease. I think most people, when you talk to them, would argue that chemotherapy is definitely needed. The question is when. Does it need to be neoadjuvant or perioperative or just adjuvant? And I think most places are trying to do neoadjuvant, but we don't have strong data for it yet. Is it a test of biology? Does that reduce the tumor burden? One of the hopes is the Dutch group is running currently what's called the Cairo 6 trial. The phase 2 portion of that they presented data on last year, which was just a feasibility study for neoadjuvant chemotherapy before cytoreduction. And what they showed was about 40% of patients with peritoneal disease had a significant pathologic response if they got neoadjuvant chemotherapy. And so our hope is that this phase 3, in a few years, when we actually can see the data from it, will show that there is a benefit to chemotherapy in a randomized prospective setting. We also don't know how much chemotherapy is needed, and some groups do 3 months, some groups do 6 months, some groups do up to a year. Do you put people on cytotoxic chemotherapy for 6 months and then switch them to maintenance before you ever go to surgery? Again, these are all unanswered questions. And I think the good and the bad is with colorectal, we have a lot of systemic therapies that work. And the question is, which ones? Do you stick with 5FU-based therapies? Do you use Bev? There's a lot of argument on using bevacizumab in the peritoneal population. If they have a KRAS mutation, do you throw them on, do you keep them off the EGFR inhibitors? If they're wild type, do you put them on an EGFR antibody in the frontline setting? We know that may not be the right thing to do with liver mets, but we don't know that with peritoneal disease. Do you use the beacon regimens for RAF mutation carriers, or do you use immune therapy for mismatch repair deficient patients? These are all unanswered questions. And I think the good and the bad of colorectal cancer is the space in general for metastatic disease is changing so quickly. We have a lot more drugs, but it's harder to keep up with what's the right thing to do in the peritoneal space. So I'll switch to mesothelioma, where we have a little bit more information on the systemic side. The downside is most of the information we have doesn't come from peritoneal mesothelioma. It comes from pleural mesothelioma. Malignant peritoneal mesothelioma's incidence is about 0.5 to maybe 1 per million people, which means, at least in the United States, about 300 to 400 people get peritoneal mesothelioma every year. So an exceedingly rare disease. We know that chemotherapy works. And there have been a number of trials, MAPS-1 probably being the largest randomized trial, where we looked at pemetrexed with platinum-containing chemotherapy with or without Bev, and showed that Bev improved overall survival to about 18 months for patients that can't undergo surgery. There are a lot of single-agent chemotherapies that work as well. They're not great. The response rates tend to be less than 10%, although especially with the vinca alkaloids, there are case reports of patients, and I've had one who've had complete responses to a single agent vinca alkaloid and live for years and years and years. I have a patient that I've been following for 4 years without any disease after she did 6 months of navalbine. We also now know that immunotherapy works quite well in mesothelioma, but the question is, when do you use it? Do you use it in the upfront setting? Do you use it in the recurrent? Do you use it with chemo or without? And so these are big questions, and much of that probably relies on the biology and histology of the tumor itself. So just to talk about the MAPS trial, this is kind of our standard of care for frontline most patients with mesothelioma, although we'll talk a little bit about biology in a second. There are 2 main biologies, epithelioid and sarcomatoid, and the sarcomatoid has a much worse pathology, much worse outcomes. And in this case, it included both the few patients that had peritoneal mesothelioma, but the median overall survival for chemotherapy was about 14 months. And if you added Bev, it got to about 18 months. And so this was published in the time when we were using with Bev with everything, and it was statistically significant, but you could barely get your laser pointer through it. And so while helpful, was not spectacular, although we do tend to use Bev in the frontline setting. Immune therapy for the last 8 to 10 years has really been or last 5 to 8 years has been what's been very exciting in the mesothelioma world. There are a lot of trials of single agents of every PD-L1 inhibitor you can probably think of, as well as CTLA-4 inhibitors. Almost all of them have about a 10 to 20% response rate, independent of what line you use them in the recurrent setting. And what was particularly helpful was that these tend to show a better response in the sarcomatoid or biphasic histologies, which tend to be a much worse prognosis overall. And when you use combination immune therapy, Ipi-Nivo specifically, you saw a 25% overall response rate and a 16-month overall survival, and that was in patients with relapsed disease. And so that's pretty impressive, and that gives us a nice combination in kind of our back pocket for patients that progress on frontline chemo. In the frontline setting, there was a randomized trial of Ipi-Nivo versus chemo, and the overall survival was better for Ipi-Nivo. However, in that trial, Bev was not used in the frontline setting, and the overall survival, if you remember from the MAPS trial, was about 18 months. And so we're not sure that Ipi-Nivo in the frontline setting, especially for epithelioid patients, is the right thing to do. But for sarcomatoid, it is. In kind of the very first trial, where we got systemic therapy tested in just patients with peritoneal mesothelioma, this was about a 20-patient trial, so huge when it comes to mesothelioma settings, but still not that big. Looking at atezolizumab with Bev in the second-line setting, and all of these patients had progressed on chemotherapy. What you see is a 40 to 50% response rate, and a median overall survival that had not been reached, and a median progression-free survival of 17 months. And this is spectacular. And so this has become kind of our go-to second-line therapy for most patients that get peritoneal mesothelioma. And we have one other kind of that I like to talk about, a very aggressive way of treating peritoneal mesothelioma. This is data published out of Bruce Shabbat and Bruce Shabbat's group of Columbia, and they had about 200 patients that they treated. And it's kind of a sandwich approach. Some got systemic chemotherapy up front, but most of them had an additional cytoreduction, intraperitoneal port placement. Then they got outpatient IP chemotherapy. They alternated IP cisplatin and doxorubicin for 8 doses every 3 weeks, and then went to secondary cytoreduction. And what they're able to get was, only probably 60% of the patients that they put in actually completed the course. This is a pretty toxic therapy. A lot of the reasons for withdrawal, the most common was because of toxicity and or patient's choice. They just didn't want to go through it. However, if you looked at the total population, their overall survival was 32 months, which is pretty good considering that they didn't select patients that had optimal conditions for surgery. They took people with any amount of disease. And for those that got past the second surgery, the overall survival was pushing 5 years, which is pretty remarkable, especially because they included some people with sarcomatoid histology and some people with PCIs over 30, which never would have gone to surgery initially. We've done this a couple of times. Both the patients that we did it on did quite well. One of them survived for about 7 years, and he had a PCI of 39 when we started. And the other one is currently at 6 years and still going strong. As we do with chemotherapy as medical oncologists, we tend to say if one thing's good, let's do 2. If 2 things are good, let's do 3, and ad nauseum until we make the patient sick, unfortunately. But that's kind of what we're doing right now with a current alliance trial, cooperative group trial, looking at platinum, in this case carboplatin, pemetrexed, and Bev, plus or minus atezolizumab in the upfront setting. This is only in peritoneal mesothelioma. They'll get randomized to plus or minus atezo and then get 4 cycles with the goal of getting to surgery, and they're not limiting. Not everybody has to go to surgery, but the randomization after 4 cycles is you go to surgery, you go to maintenance atezo Bev. In about a year and a half, it's already about halfway enrolled. I've put 3 patients on this trial. I screened a 4th one that decided not to do it, and so far it's going pretty well. And hopefully we'll know this data within a couple of years. Lastly, I want to talk a little bit about gastric cancer. Gastric's somewhat of a special case, even though a lot of patients get peritoneal disease. It is such a poor prognosis with peritoneal disease. The median overall survival, if you have peritoneal carcinomatosis from gastric cancer, is somewhere in the 6 to 8 month range. It's pretty miserable. And if you look at all patients with the most recent data, chemotherapy plus HER2 targeted therapy plus PD-L1, the median overall survival from that trial was pushing 20 months. And so I think in general, like with other diseases, those with peritoneal disease do much worse, and we need to think of some better way to treat them. In gastric cancer, treatment is biomarker driven all the way back to 10 years ago, plus for the TOGA trial with HER2 targeted therapy to CheckMate, plus infinite others with single agent immune therapy added to chemotherapy, to most recently KEYNOTE-811, which actually was just published 2 weeks ago, I think, or 3 weeks ago, looked at adding chemotherapy plus HER2 targeted therapy plus PD therapy. And for those patients that can survive the quadruple therapy, they tend to do pretty well. However, in almost all of the patients in these trials did not have peritoneal disease. So what are some novel ways that we can treat peritoneal disease with gastric cancer? Well, our partners in Asia are much further ahead of us than we are in the United States and in Western Europe, partly because of the incidence of gastric cancer is so much higher. And so there have been a number of trials there looking at intraperitoneal chemotherapy, not HIPEC, but as an outpatient intraperitoneal chemotherapy. And so the kind of starting with that was with S1, their version of 5FU and Taxol, and there were a few trials published out of a group from the University of Tokyo in 2010 and an update 2012 with about 100 patients. So they did 3-week cycles. They got S1, 5FU for the first 2 weeks, and then got IV and IP, not PI, IV Taxol on days 1 and 8 of a 21-day cycle. And what they found was a 1-year overall survival of 80%, which is pretty amazing considering the median overall survival for these patients with just systemic therapy is 6 to 8 months. 60% response rate and an almost 2-year median overall survival. This was pretty impressive. And this is their data on the right. This is their original data on the left-hand panel and the updated data in the right-hand panel. And what they found was people that didn't have ascites but had positive peritoneal disease, which is the blue line versus the purple line. And sorry about the backgrounds, but that's how they published them, so I couldn't do much about it. And on the right-hand side, where they had localized peritoneal disease to the stomach adjacent areas as those that had distant peritoneal disease, which is the purple line here, did really well with this IP therapy. And so I think this is something that other people have looked at, but it hasn't been taken up much outside of Asia. We started doing this about 8 years ago. We've treated about 15 patients with this protocol. We use Xeloda instead of F1 or instead of S1, excuse me. We presented this. It hasn't been published yet. We presented it at Society of Surgical Oncology a couple of years ago. Our median progression-free survival was 13 months and had almost a 90% 1-year survival and a median OS of 2.5 years. And so doing much better with this protocol. And it's actually the intraperitoneal Taxol is fairly well tolerated. I have patients, the biggest complication I've had is I had an unfortunately fairly obese woman whose intraperitoneal port slid out and she got subcutaneous Taxol at least once. And even in her case, didn't have significant problems with it other than just having a bad rash where the Taxol went subcutaneously. So this is actually a fairly well-tolerated regimen. And lastly, what I really want to talk about is palliative care. And I think this is probably what's most important to our patients with this disease. Peritoneal disease causes really unique peritoneal pain. And I think it's something that we don't often recognize in our patients. And it's very inflammatory in nature. And these patients do remarkably well if you give them steroids. It's just a low dose of steroid can really turn around some of their pain syndrome that they get. Many of these patients produce copious amounts of mucin. We've done palliative HIPEC just to try to reduce the mucin production with some success. I won't say it's been as successful as we want it to be. But we've definitely had patients who end up with the quote unquote standard jelly belly that if you go in and clean out the mucin and do HIPEC without trying to do a true cytoreductive surgery, you may not change their survival, but you change the mucin production, which gives them better quality of life. There's some data with COX-2 inhibitors. We use celecoxib that may slow mucin production down. Most of that was done by Chowdhury and Dave Bartlett and their group up at Pittsburgh. I've had mixed success with that. It's a relatively innocuous drug in these patients to give them as kind of a pain control agent as well. Probably the biggest problem we see is bowel obstructions. And I think this is where we can make the most difference for our patients because almost everyone with peritoneal disease develops bowel obstructions and you have to be aggressive with these patients. I have this talk with every one of my patients when they come in and almost every time I see them is talk about, are they having any symptoms? They all know if they start having pain, they start throwing up and kind of have the initial signs of partial small bowel obstructions, to just stop eating, to be NPO at home for close to 24 hours, take a little bit of water and that's it. If they don't get better in 24 hours, they come straight into the hospital and we admit them and we have pathways to take care of them with bowel obstructions. All of our patients are given low residual diets. These are the anti-physician diet, as best I can tell. It's everything that most doctors tell you not to eat: low fiber, easy to digest carbs, sugars, things like that, so that they don't end up with large stool burdens that can help enhance the kind of bowel obstruction problems that they have. And all of these patients are on very aggressive bowel regimens. And so I think my goal for this from a systemic therapy standpoint, I think that's my last slide, is that the take home is that this is really a multidisciplinary problem, and we have a multidisciplinary clinic set up where myself and my two surgeons that do our debulking surgeries see our patients on Thursdays together, with the goal that we can make decisions as a team and help take care of these patients and get them the right care that they need. And the other side is we're heavily working on trials for systemic therapy. There have been some signals for maybe some drugs that work in appendix cancer, and so we're currently writing some trials up for that right now, with the hope of trying to be a little bit more tailored towards peritoneal disease as opposed to just using whatever chemotherapy tends to work in the primary cancers, unless that's the right thing to do. So that's all I have. Apologize if I went over a little bit.
Thanks so much, John. That was great. And we have a number of our palliative care colleagues on the line, I can see. So I'm sure they'll be very happy for you pointing that out towards the end, that really multi-D approach and a focus on symptom management is really important with this difficult disease. So I'm going to just introduce now Mr. Pader Waters. Pader, if you want to go ahead and share your slides, and then we'll take some questions towards the end in the last few minutes. So Mr. Waters is one of our colorectal surgeons here in Cork University Hospital. He's been with us since January of 2022 and formerly a graduate of NUI Galway, completing his higher surgical training in 2018. He has a master's and an MD in research from NUIG in the past, and also a master's in clinical education, and has published over 80 peer-reviewed papers over his career to date. Pader actually travelled to Australia to the Peter Mac Cancer Centre, where he underwent an advanced colorectal clinical fellowship in robotic surgery, pelvic exenteration, and cytoreductive surgery. And he also did a further surgical fellowship in the Royal Brisbane, and worked as a consultant colorectal surgeon in the Peter Mac in Melbourne, Australia, until he returned to us in CUH. So we're delighted to hear the surgical perspective, Pader, on this disease. Thank you.
Thanks, Roisin. Can you hear me okay, and can you see my screen? So good afternoon, everyone. I'd like to thank Roisin Connolly for inviting me to talk today. Just as a way of introduction, I, as Roisin said, finished surgical training in 2018 and travelled to Melbourne to do a colorectal fellowship here in this cancer centre called the Peter MacCallum Cancer Centre. It's located in downtown Melbourne. So this is the biomedical precinct in Melbourne, where you have the major cancer centre here in the middle, the Peter Mac. At the back, you've got the major trauma centre called the Royal Melbourne. Next door, you've got the largest obs and gynae unit in the Southern Hemisphere called the Royal Women's. Down the street further, you've got the Royal Children's Hospital in Melbourne, and then you've got the University of Melbourne across the road with all the biopharma and labs. So the Peter MacCallum Cancer Centre was the State of Victoria Referral Centre for peritoneal cancer and for pelvic exenteration. The population we treated was similar to the Republic of Ireland, roughly about 4.8 million people. So we treated all the peritoneal cancer for the state of Victoria. Like John stated, I'm going to talk predominantly about colorectal peritoneal metastases for this talk. I'm going to touch very briefly one or two slides on ovarian cancer, and I will not be covering primary or mesothelioma. So unfortunately, the peritoneum is the third most common site of metastases. And at surgery, in approximately 7 to 10% of patients, unfortunately, at primary surgery, we find evidence of peritoneal disease. Interestingly, though, 25% of patients will have METs confined only to the peritoneal cavity. So aggressive treatment, patients can do well. But unfortunately, between 40 to 80% of patients currently globally still die from this disease. They present in a wide spectrum of formats. So we can see here on the left, this patient presenting with what John labeled as a jelly belly, or would be significant abdominal distension with compression type symptoms. So this is likely a mucin secreting tumor with peritoneal disease, likely from an appendix cancer. Or else they can present with this here on the right, which is called miliary peritoneal disease, which is radiologically occult disease. And these are the type of patients that we just come across at the time of their potentially curative surgery. So patients that are at high risk for developing peritoneal disease are the following. So obstructing tumors, bleeding tumors, T4 disease, patients that have positive cytology or positive lymph nodes on their surgical resection specimen, and patients who have signet ring morphology or mucinous tumors. But the patients that we get really worried about at the colorectal MDT are those who have perforated tumors, or women who present with ovarian metastases at the time of diagnosis or on follow-up. And these are called Krukenberg tumors. And unfortunately, these patients have significantly high risks of developing peritoneal disease. Sorry for the projection of the slide, but essentially shows the poor outcome of patients presenting with perforated cancer. We can see here in this Kaplan-Meier curve that if you present with a perforated cancer, you've got a significant risk of developing peritoneal disease over time, and also local recurrence. So if we know the risk factors of developing peritoneal disease, can we do anything to try and prevent it? And these were two trials looking at that. So ColoPEC was identifying high-risk patients, assigning them to either primary surgery and standard follow-up versus primary surgery with HIPEC, which did not show any evidence or difference in 18-month peritoneal metastasis-free survival. And Profilo-CHIP, again in colorectal cancer patients with high-risk features, doing a primary section versus standard adjuvant therapy, followed by HIPEC. And unfortunately, at 3 years, there's no difference in 3-year survival. So prevention didn't seem to be working. So therefore, treatment is very important. But unfortunately, this is one of the Lancet publications by Franco et al. In 2016, showing that patients who present with stage 4 disease, that peritoneal cancer metastases do far worse than those with lung and liver. That's denoted here by the purple line. So their survival is significantly worse. And again, this is borne out in other studies. John has mentioned this. So in the Dutch trials, Cairo 1, Cairo 2, patients who present with stage 4 disease, whether they have peritoneal disease or not, those that have got evidence of peritoneal carcinomatosis have a significantly reduced median overall survival. So what do we do with patients who have colorectal cancer with peritoneal disease? Well, the options are limited. They're getting better. So best supportive therapy, palliative care, not as practiced as much nowadays because we do have better chemotherapy options. But there are issues with systemic chemotherapy, and I'm going to discuss that in the peritoneal setting. You can also offer them cytoreductive surgery with systemic chemotherapy in the neoadjuvant or adjuvant setting, or else cytoreductive surgery with intraperitoneal chemotherapy followed by systemic chemotherapy. So best supportive measures, John mentioned this, they don't do well, median overall survival between 5 and 7 months. There is no doubt within the metastatic colorectal chemotherapy world that we have gotten far better at treating this. So now patients can, with more targeted therapies and better understanding of tumor biology, can now sustain a potential increased survival of almost 2 years. So there's certainly improvements on that. But chemotherapy in patients with peritoneal disease has got limited efficacy, and that's multifactorial. Number one, the peritoneum is very poorly supplied by blood. So therefore, delivering chemotherapy in the standard way by intravenous chemotherapy, there's poor penetration. Furthermore, there is some chemoresistance, especially patients presenting in the Tacrona setting can have chemoresistance. There's also discussions out there with regards to different tumor biology. So it is anticipated that there's different tumor biology within the primary and the peritoneal deposits. And furthermore, there are limited responses to chemotherapy. If you look at radiology and following patients through the MDT, up to 70% of patients show very little response to chemotherapy agents. So this led to the development of cytoreductive surgery and intraperitoneal chemotherapy. And that was popularized by a US surgeon called Sugar Baker, who's doing this for very low-grade tumors of the appendix, the ovary, and in cases of mesothelioma. And it's essentially applying the same concept to treating patients with colorectal liver metastases. You resect the primary along with the metastases and then instill intraperitoneal chemotherapy to tackle any microscopic disease that may be left behind that would increase the risk of developing peritoneal dissemination. So what does it involve? Well, it involves peritoneal stripping. So this is a patient in the, you can see here in the right upper quadrant, the peritoneum is approximately 1 to 2 millimeters in thickness, and it's resecting this lining within the abdominal cavity to remove the tumor en bloc. So this is the patient's right upper quadrant. You then proceed to doing a visceral resection, so removing the primary tumor along with any deposits, so as you can see here in the omentum or in the pelvis. And then you do thermal ablation to any tumors that you cannot resect, such as tumors that are high up in the mesentery of the duodenum or the jejunum, or sometimes within the liver capsule. So this is one of my patients from 2021, a young lady who developed peritoneal carcinomatosis. And this is her diaphragm stripped. So I've gotten consent to present these videos and pictures for educational purposes for all the patients, because there will be some videos in this talk. So this is the patient's diaphragm peritoneum lining. So this is stripped out with all the different tumor deposits. And this is the patient's undersurface of their liver. There's some thermal ablation to some deposits in the liver, and the omentum along with the tumor is fully removed. So this is a video here. So this is the patient's right upper quadrant again. This is the diaphragm moving. The muscle is exposed because we removed the diaphragmatic peritoneum. This is the undersurface of the liver with the kidney exposed over here. So the peritoneum is stripped back, and we'll put the liver back into place here now. We can see that there's tumor within the diaphragm, and it's left back in place, and this all gets resected out. So after you remove the primary tumor and you remove the peritoneum, chemotherapy is delivered into the abdominal cavity, and you can reach peak peritoneal concentrations of 200 to 1,000 times greater than can be achieved in standard intravenous delivered chemotherapy. And very interestingly, the patients do not have much in the way of systemic disturbance or side effects. And intra-abdominal chemotherapy can penetrate the tissue up to 2 to 3 millimeters in depth. We add heat, so the chemotherapy is heated in a heat reservoir between 42 and 44 degrees Celsius, and that increases the tissue penetration of the drug. It increases the cytotoxic effects of the chemotherapy agent, and heat itself is cytotoxic in nature. And this is how it's delivered. So this is a delivery perfusion machine. The chemotherapy is placed into the reservoir. It gets pumped through a heat exchanger. It gets heated up to 42 degrees Celsius and then passed into the abdominal cavity with inflow catheters. And then it is distributed around the abdomen, and it's then aspirated back out of the abdomen by catheters in the pelvis, which goes back into the reservoir. This is the open technique of delivering chemotherapy in the Peter MacCallum. This is the theatre complex here. This is a cardiopulmonary bypass machine, and that's what we used as the perfusion instrument. While I was there, we changed to doing the delivery of chemotherapy in a closed technique. This prevented spillages of cytotoxic agents. Plus, it also allowed greater coverage of chemotherapy into the wound, and it prevented and reduced wound implants. So you've got an inflow catheter here and then an outflow catheter that goes back to the machine for distribution of chemotherapy. These are the different machines. So the only country currently doing peritoneal surgery at the moment is the Mater Hospital in Dublin. And they use the machine here on the left called the SunChip machine. It's very easy to use. The nurses in theatre actually control this machine. And this is the one we use in the Peter MacCallum Cancer Centre. More complicated. We had a perfusionist that would come for each case, and it's a cardiopulmonary bypass machine. I won't labor on this, but John has mentioned this already. So this is a sentinel study coming from the Dutch group showing that, you know, with HIPEC and cytoreductive surgery versus standard therapy, that it did improve disease survival and progression-free survival in patients with colorectal cancer. And again, this was also mentioned certainly from Ilias's group in France. They showed that, again, HIPEC versus standard therapy, there was improved 2-year and 5-year survival. There are some limitations to these studies. They had older chemotherapy regimens, and also they include appendiceal cancers, which behave differently from a biological perspective. So just one concept that's very important to note, and certainly when we're discussing these cases at the colorectal MDT, is what's a PCI. So PCI is a peritoneal carcinoma index, and it's the way to score the disease burden within the abdominal cavity. So the abdominal cavity itself is divided up into 9 regions, as we can see here on the patient on the left, and then the length of the small bowel is divided up into 4 other regions. So that's 13 regions in total. And the maximum score they can get for cancer burden within any compartment is 3. So if a patient has no tumor seen, they get a score of 0 in that compartment. Less than 5 millimeters, they get 1. Less than 5 centimeters, they get 2. And if there's tumor burden greater than 5 centimeters or confluent disease, they get a score of 3. And that's scored out of 39. It's important to discuss CC scores. So this is something that the gynae oncologist would also be quite used to, but a CC0 means getting a full complete cytoreductive surgery, i.e. not leaving any tumor behind and resecting all peritoneal deposits. And that's important because it does influence survival. And again, by Ilias's group in France, they showed here by getting a complete cytoreductive clearance, getting rid of all the tumor, it does confer better overall survival. in time. Interestingly, when they did a multivariate analysis, they show that patients with a lower PCI score, so that lower score out of 39, showing less burden of disease, having a complete cytoreductive surgery done, negative lymph nodes, and those able to get adjuvant chemotherapy did far better from a survival perspective than those that could not. And again, the PCI score that we currently use in colorectal metastases, it's different with appendiceal and gynae, but with colorectal disease, we usually use a cutoff of PCI of 15. So that's what's currently used internationally from a cancer burden perspective to decide whether patients go forward for cytoreductive surgery and HIPEC versus chemotherapy. This is some outcome data from our own patients. We looked at 100 patients with colorectal mets within the peritoneum undergoing HIPEC and cytoreductive surgery. And again, we can see here by their survival curves that getting a CC0 resection, it does improve significant survival, and certainly more patients who have a lower tumor burden. So again, that magic number 15 or less, their survival is far better than those who had an increased tumor burden of greater than 15. When we looked at our multivariate analysis, patients with mucinous subtype tumors, and again, those who did not get a complete clearance, did significantly worse from a survival perspective. There's been numerous studies over the last decade showing the favorable survival benefits of patients undergoing cytoreductive surgery and HIPEC. And certainly this is seen in other streams, both in the ovarian setting and also in the gastric cancer setting. So when a patient presents, how do you work them up? Well, if they've got high volume disease on their radiology at diagnosis, the key is to resect or defunction them if they're symptomatic. And if you can do that in a minimally invasive fashion and get them to systemic chemotherapy as quick as possible, that is the key for these patients to improve their survival. If it's low volume and you think that their PCI is less than 15 on radiology, you send them to a peritoneal center for consideration of CRS and HIPEC. If patients have had their primary surgery done and they come back with metachronous disease or deposits within their peritoneum outside of their primary section, then the key is to assess the extent of disease. And that's by doing radiology and laparoscopy. So I hope this video is coming across okay, but this is a laparoscopy of a patient who was sent to me in Melbourne who had significant burden of disease. So we can see here that that patient would get a score of 3 in the left upper quadrant and a score of 3 in the right upper quadrant. So this is a laparoscopy trying to decide, do they go down the chemotherapy route or do they go straight for surgery? So we can see here a significant burden of disease. And I'm going to play this video and tell you what we did with this patient in a little time. And patient selection is key here. Sorry, I'll mute this. Patient selection is key here because they do, as John said, go under prolonged surgical interventions. They're very morbid interventions. So this is one of my patients who had a appendiceal cancer. This is their liver being dropped back into position. Their right diaphragm is stripped. They've had a capsulectomy of their liver with some ablation to other parts of their liver. This is the hepatorenal space, and that's stripped from their peritoneum. Their liver, kidney over here on the left, their vena cava. As we move the video on, we can see that the majority, the greater and lesser omentum, is removed. That's the stomach there, which is again left on its vascular pedicles. The left upper quadrant is fully resected from a peritoneal perspective. And this is the pelvis. This lady had a right hemicolectomy, and we can see here that she also had a pelvic peritonectomy, and her both ovaries have been removed. She did egg harvest. She's 28, and we've kept her uterus in place for potential conception down the line, but she did very well with favorable biology. What has rocked the world within the surgical domain really was this study, Protégé 7 from the French group, was a multi-center randomized control trial looking at overall survival as an intention to treat model of overall survival in patients undergoing cytoreductive surgery with HIPEC or just cytoreductive surgery alone. And they found that their primary outcome was overall survival, that there's no difference whether you used HIPEC or not. But there was numerous issues with the study. They had good overall median survival of 41 months, but there was some crossover of patients. And when you included the 16 patients that actually went into the HIPEC group, there was a significant difference in survival. Furthermore, when we looked at that magic number of 15 or less, we can see here that HIPEC within this group was critically important, and there was a significant improvement in survival in patients who underwent cytoreductive surgery and HIPEC. What agent do you use for gynecological malignancies? It's cisplatin. For ovarian or for appendiceal and colorectal, it's a mix between oxaliplatin and mitomycin. There's a lot of heterogeneity internationally with what agents are used and for how long they are instilled into the abdominal cavity. But overall, in this forest plot here, you can see from a meta-analysis recently published that there was no difference in whether you used oxaliplatin or mitomycin C. So from the 19 different countries, we can see 10 use oxaliplatin and 9 use mitomycin with different perfusion durations. Very briefly on ovarian cancer, OVO-HIPEC-1 proved benefit for surgery plus HIPEC. This most recent meta-analysis published in 2022, again looking at the forest plot for progression-free survival and overall survival, favoring patients undergoing cytoreductive surgery and HIPEC versus cytoreductive surgery alone. And this is currently underway of HIPEC-2, which is due to be published in 2026, and it's for stage 3 epithelial ovarian cancers. And they're looking to assess overall survival in patients undergoing HIPEC. And I believe the Mater Hospital in Dublin are submitting patients to this. So contraindications to cytoreductive surgery in colorectal cancer: if they've extra-abdominal disease, if they've got significant retroperitoneal lymph node involvement, if they've got greater than 3 liver mets. So it can also be carried out in patients with liver mets. If they've got 3 or less liver mets, the PCI does drop to 10. We don't have enough time to discuss that today, but they can be offered to patients who does have liver mets. If patients presenting with a PCI greater than 15, we typically didn't offer it in Australia. And if they have unresectable miliary disease here on the right, we didn't offer them HIPEC cytoreductive surgery. John brought up a really important point about what do you do with the palliative patient. And certainly this is something that we did quite a bit of in Melbourne. We used PIPAC, which is a minimally invasive approach to treating patients who have got high burden of peritoneal carcinomatosis. So this is a video showing a patient undergoing PIPAC. It's delivered through a high pressure pen called a capno pen. So chemotherapy is aerolized under pressure and it's delivered into the abdominal cavity. So this is my patient here. The head is to the top of the table, legs to the bottom. It involves a small incision in the umbilicus to put in the balloon port. The capno pen is placed through this 10mm port. A 5mm port is put in the left flank just to see here at laparoscopy what's happening. Again, it's all of this is coming from the German and the French group. The chemotherapy is delivered through a high pressure injector. We used an aortic delivery system. This is it here. That's a system for using delivering dye in to get an aortogram. And this is the theater. The theater is cleaned out, nobody's present, and the PIPAC is delivered into the abdominal cavity. And this is what it looks like intra-abdominally. This is the capno pin in place. The chemotherapy is being delivered intra-abdominally. And really what happens is you generally do 3 cycles of this. And if the patient shows effect, you can do up to 6 cycles. They start to get a cytotoxic effect after the first delivery. After the second delivery, they start to get they get an inflammatory response for the first effect. Then after the second delivery, they get a cytotoxic effect. And then after the third delivery, you start to see sclerosis and anti-angiogenesis. And this is that lady I showed you earlier. She wasn't a surgical candidate because her PCI score was too high. So she underwent PIPAC, and you can see here significant sclerosis of her tumor. She remained very well from a symptom perspective. For time, I'm going to just pass through. One of the main points for PIPAC is not to do it in the setting of small bowel obstruction. So it's contraindicated in small bowel obstruction. And it can very much be personalized. So we have many patients who will be on both PIPAC and neoadjuvant chemotherapy in the same setting. They do mention patients getting to cytoreductive surgery and HIPEC with treatment, but that is in single digits. These are the only centers doing it globally at the moment. There's none currently in Ireland. It's a minimally invasive way to deliver chemotherapy. And for time, I'm just going to get through this. Nice, just say that yes, HIPEC should be offered in centers for patients with colorectal mets, but again, it's an MDT decision, and all these patients will be discussed at a colorectal MDT. So in conclusion, peritoneal malignancy remains a significant problem. It should be considered the same as lung or liver metastases. Cytoreductive surgery and HIPEC is a therapeutic option for patients with peritoneal malignancy. And I do think there is a personalization here with regards to therapy, whether that's in biomarkers or organoids. and we need to also overcome drug resistance. Thank you.
Thanks so much, Peadar, and thank you both for trying to keep to time. I know we started a little bit late today, but appreciative of everyone being in attendance. Just one or two questions had come through already early on, and so we might direct the first two questions to Dr. Hayes. And these are coming again from our palliative care consultants. So John, could you speak to quality of life data in this cohort if it's available, and also the selection criteria? I'm not sure what the HPN is, perhaps you can remember, but some selection criteria for a palliative intervention in patients presenting with recurrent bowel obstruction, home parenteral nutrition. Thanks, Mary.
Yeah, so I think unfortunately in oncology, quality of life was overlooked for many, many years until probably the last 5 to 10 years, people really started looking at quality of life in trials. And so we have limited data on true good quality of life data for many of these patients in our clinical trials. I think I would say colloquially, most of us think that really getting our palliative teams involved or getting these patients to centers where they take care of people with peritoneal disease has shown definitely an increase in survival, and I would like to think quality of life, but again, I don't have objective data to state that. As far as parenteral nutrition, that's a really good question, and I think historically surgeons and medical oncologists have had very different opinions on parenteral nutrition, and I think I agree that parenteral nutrition can be helpful in patients with bowel obstruction. I think you need to have some sort of end game from a parenteral nutrition standpoint, and that is, it is a very high risk procedure. And if you have somebody that needs TPN to be able to survive, and that patient's going to need chemotherapy going forward, there's already a high risk of sepsis or liver toxicity with the TPN itself. And if you throw chemotherapy on top of that, that's a tough situation. I've treated probably 10 patients on TPN with chemotherapy, and at least 3 of them have died from sepsis. And it's really tough. And I think sometimes what we try to do is offer, if patients have malignant bowel obstructions that is not clearing, we try to offer TPN, or we offer kind of palliative venting procedures. But in most cases, that's when we're not going to be going through systemic therapy anymore. I tend to, when I've been aggressive is when patients are kind of at the front end of their disease, either their new diagnosis with bowel obstruction, they've never seen systemic therapy, and there's still a pretty good chance that we could actually get a response out of chemotherapy and or surgery with the hope of getting them off of the parenteral nutrition at some point.
That's great. And then there's another question there from Richard Bambury around the role of IP delivery of novel anti-cancer therapies such as TKIs or immunotherapy.
I've been yelling at companies for 5 years trying to get trials where I could deliver anything I could get my hands on intraperitoneally, and most companies don't like the risk associated with it. I think there's been a little more interest more recently in some of the novel immune therapies being delivered intraperitoneal. We have old historic data for delivering IL-2 intraperitoneally. It's very toxic. But for some of the newer, not only checkpoint inhibitors, but some of the bispecifics and things like that, to try to do them intraperitoneally is currently being talked about, but I don't know of any data that's out there.
So it sounds like, it sounds like huge opportunities anyway for research and clinical trials. And as Peadar mentioned, collaboration in terms of passing, samples back to, laboratory research. I know, John, you have a lab which focuses on that in Ohio State. So again, this multi-D partnership to ensure that the patients are cared for optimally between surgery, MedOnc, PalCare, and our researchers.
I have a quick question for Peadar. So we have not done PIPEC here. As you said, it's fairly limited where it's used in the world. There's one center in the United States that has it open and available, and there are about 10 others, and we're in that kind of second way of getting it. But from a quality of life standpoint, what are the differences between people getting PIPEC and people getting cytoreduction and HIPEC? Because it sounds like it's a much better tolerated being used in a palliative setting.
Yeah, I mean, you did touch on it during your talk, where you talked about some patients with significant mucin production that do undergo, palliative HIPEC. So you do clear out their abdomen mucin and deliver in intraperitoneal chemotherapy. Again, they've got to go through the morbidity of having a laparotomy, which is the problem, whereas PIPEC is delivered through 2 1 centimeter incisions in the abdominal cavity. The patients that do, I don't have any objective data. I've only got data from patient reports, because we've done now roughly about 10 in the Peter MacCallum Cancer Centre. And your selection criteria is very, carefully done, because majority of patients who have go for PIPEC have high PCI scores. So by nature, they're at high risk of developing small bowel obstruction. And one of the contraindications to PIPEC is the potential impending small bowel obstruction. So there are few patients that are suitable for it. But I have to say, it's a very well tolerated procedure. They have come in the morning of surgery, have it done and go home the next day. There is increased pain with the first delivery of PIPEC that we don't see on cycle 2 and cycle 3. But anecdotally, the outcome from the patient is that it's very good. We would biopsy them looking for tumor regression on each PIPEC delivery. So we'll biopsy each time looking for regression of tumor to see if it's being effective. But from the ascites perspective, it significantly reduces the burden of ascites in patients undergoing PIPEC. And we've had good outcomes from a symptom control perspective.
Great. Well, thank you both so much. That was fantastic. And we might wrap up now in the interest of time, and looking forward to seeing you all on the next seminar series in 1 month's time. And Katerina will be sending out the link for same shortly.